It was the worst day of my life. I said goodbye to my family because I was convinced I was going to die. I couldn't breathe, I couldn't think, I couldn't see straight. It was in that moment that I realized my mortality. These are all direct quotes from patients that have had a panic attack. All of these patients were under 35 and had no chronic or acute illnesses. What was it that brought them such terror? Panic, one of the most common but one of the least understood episodes of anxiety. Anxiety disorders are the largest and most common family of mental illnesses. If we expand further to look at subsyndromal levels of anxiety, worry, panic, and phobias, we're talking about something that has affected all of us. As I've mentioned before, distress is not a disorder, and we shouldn't pathologize everything. But as with depression and sadness, or really any emotion, we want to look at the utility or value of what we're experiencing. Does our anxiety have a purpose? Is it communicating any new information? Does it direct us to solve a problem or work through a conflict? Is it long-lasting or is it acute? Is the severity excessive? Depending on how you answer these questions, you may or may not need to address your anxiety. Now, recall we've already talked about worry and we've talked about rumination in Lecture 7. We've also talked about exposure and somatic quieting as general behavioral tools, and we looked at general emotion regulation skills that included anxiety as a target. Later, we'll dig more deeply into social anxiety, and especially anxiety around being rejected. So in today's lecture, we'll look at the common and quite frightening phenomenon of panic attacks. But before we go there, let's take a broader look at anxiety and where CBT fits in. First, some definitions. Fear and anxiety are psychological and physiological responses to danger. In general, fear is conceptualized as an emotional and physiological response to a definite threat. Think about fight or flight reactions. Fear is basic, primal, and gripping. Its purpose is really to keep us alive. Anxiety is a diffuse, unpleasant, vague sense of apprehension. It's influenced by culture, by cognition, by personality, and a number of other internal factors. Anxiety can trigger fear, and fear can result in lingering anxiety. Fear is more present moment, and anxiety is more future focused. But what about normal anxiety versus an anxiety disorder? There's a few things we need to think about. Now remember that fear and anxiety are protective emotional reactions in response to real or anticipated threats. Fear and anxiety can be healthy and helpful. They're central to our harm avoidance system. There's a wide range of normal in the population and large cultural differences in what might be considered normal or abnormal. The diagnosis of an anxiety disorder is based primarily on the degree of interference with normal function at work or in your social life. Anxiety disorders refer to a heterogeneous group of syndromes characterized by abnormally increased sensitivity to fearful stimuli, inappropriately intense experiences of fear or anxiety, or inappropriately extreme action based on that anxiety. For anxiety disorders, the anxiety has gotten so extreme it's taken on a life of its own, and in a way, the disorder becomes the stressor. It becomes a mental illness. Now, there are a number of different treatment options that I want to mention, and of course, we'll be focusing on cognitive and behavioral tools. First, I wanted to say just a word about medications. For medications, there are three primary categories. There are the benzodiazepines. These are things like Xanax or Ativan or Klonopin. Now, these are quite effective in turning down that physiologic response, but they have a number of side effects, and they are also habit-forming and can be abused. There are the antidepressants, and here I'm mostly talking about the SSRIs, the selective serotonin reuptake inhibitors, things like Zoloft or Paxil or Celexa or Lexapro. Now, these are sort of the broad-spectrum antibiotics of the psychiatric world, developed initially for depression, but they also seem to be helpful for anxiety. And fortunately, these are not habit-forming. I will say a word of warning, however, if someone is on an SSRI for a long period of time, when they stop, there's sometimes a rebound syndrome. So it's best to taper down slowly, even though these tend not to be habit-forming. And the last category are beta blockers. Now, if you have hypertension, you know exactly what a beta blocker is. It lowers your blood pressure, or essentially it turns down some of those physical sensations or symptoms that we see when a person's anxious. Sometimes people with a public speaking phobia will take a beta blocker so their voice sounds even and they don't have the jitters. And of course, treatments include cognitive interventions, behavioral interventions, and these aren't just for anxiety disorders, they can also be relevant for subclinical anxiety. So let's look then at some of the components from CBT for anxiety disorders or for subclinical anxiety. Some of the behavioral components are exposure to a feared stimulus. Here we want to diminish avoidance and safety behaviors. It temporarily raises anxiety, but in the long run, it will diminish anxiety. Cognitive interventions include challenging thoughts. Behavioral and cognitive strategies that are mixed might be things like reality testing, developing a sense of mastery, or some of our somatic quieting or relaxation techniques. Now, I want to say a word about a fairly well-researched and well-established system of treatment for anxiety disorders, particularly for something like phobias or generalized fears. It's something called a SUDS hierarchy, or a systematic desensitization that uses a SUDS hierarchy. SUDS, S-U-D-S, are systematic or subjective units of distress. What an individual does is they create a ladder, a ranking of things that cause them anxiety. If you're someone that has a phobia of spiders, 100 would be holding a tarantula in your hand. A 0 might be sitting on your couch reading a book that has nothing to do with spiders. A 10 might be looking at the word spider. A 20 might be looking at a pretty good but plastic spider, and so on up the hierarchy until you get to 100. Here you do graded exposures. You start at a low level, feel that anxiety begin to rise, use your somatic quieting until there's no more anxiety. Then go to the next level, and the next level, and the next level. It's a more gradual, gentle way to do exposure therapy. But sometimes there are good reasons to feel anxious. For many young people, particularly those raised in abusive families or who live in poor or violent neighborhoods, anxiety is a rational reaction to unstable, dangerous circumstances. Recall that the cognitive theme of anxiety is the misperception of threat and the estimation that our coping resources are insufficient. Our habits of mind might come into play, causing us to overestimate the severity of threat and/or misjudge our ability to cope. When self-assessing or assessing others, we have to be very careful about assuming that a threat is misperceived or resources have been underestimated. Both scenarios are important, but they call for different kinds of interventions. Is it anxiety? Or maybe it's fear, a real and definite threat on the horizon. So before I introduce a new case, a young woman that had a very dramatic panic attack on an airplane, I want us to review what we've already learned about anxiety, cognitions, and behaviors. If you go to our worry lecture, we talked about how thought records can help, but they aren't really the preferred treatment due to the nature of anxiety. We just can't get the perceived risk down to 0. Thought records can help balance beliefs about the danger of uncertainty or the value of worry, but we really need to look at behavior to get anywhere. So let's review behavior. Recall that the most common behaviors that occur with anxiety are avoidance and safety behaviors. We avoid whatever we fear, that threat on the horizon, be it real or imagined, and we try to do things to keep ourselves safe. Neither of these behaviors challenge our anxiety, but they do help us feel better in the short term, which is why we keep doing them. Safety behaviors would include things like reassurance seeking, checking and rechecking your locks, calling your doctor or the advice nurse at your health clinic, or making your spouse reassure you over and over and over again. Safety behaviors also include excessive preparation and rehearsals, or maybe even an excessive reliance on somatic quieting. I have had some patients who become so obsessed with breathing just perfectly that breathing becomes a way to distract themselves from their anxiety and to feel more safe. The patient we're about to meet has another safety behavior. She keeps a Xanax with her at all times in her front pocket. She rarely takes it unless she has to take a flight, but she believes she needs it on her person at all times in order for her to stay safe. So here's our new case. Kathleen is a 30-year-old single woman in good health who recently had a severe panic attack while on an airplane. So much so that the plane had to return to the gate so she could be taken off the plane and sent to a nearby emergency room. After a medical workup, she was told that she had a panic attack and that she was, quote, fine. Well, she didn't feel fine, and she was terrified of getting on a plane ever again. And so began her totally unexpected introduction to anxiety. So what is a panic attack, and how do you know if you've had one? Let's hear about what happened in her own words. Kathleen, welcome. I'm Dr. Satterfield, and I'll be working with you on your anxiety today. I see from your intake that you recently had a panic attack. Is that right?
Yes.
Okay. I think it would be helpful for us to better understand the details. And I know you've shared it once before, and I do have the description, but I'd like to listen for your own words about how you saw the whole thing starting, how it progressed, and eventually how it resolved itself. So can you tell me about that first attack?
Yeah. So I was recently traveling, and my flight, we ran into some technical issues with the airplane, so we were waiting on the tarmac as they were determining what to do. So we were there for a little while, and the longer we sat there, the more I think I just kind of realized it was a small space. It's an airplane, so the airflow isn't great. And I just started to I could feel that my heart rate was getting rapid, and I was starting to hyperventilate a little. And I couldn't kind of calm down. So when the plane did have to go back so we could get a new plane, I ended up actually going to the emergency room because like I said, I had a rapid heart rate and I thought I was having a heart attack until a doctor diagnosed it as having a panic attack.
Okay. So it sounds like it must have really escalated and went from
Yes.
I'm uncomfortable on a plane and feeling kind of anxious to, oh my God, right? I'm
Yes.
having, so what period of time did that happen in?
It was probably within 20 minutes from when we were sitting on the plane.
Okay.
Probably a few minutes into that I started to panic. And as it escalated, I didn't think it was panic. I thought it was a heart attack.
Heart attack, yeah.
And about 20 minutes later when we were off the plane.
Okay. And it sounds like they were concerned and sent you to the ER, and they
Yes.
did the ER thing and
Yes.
decided that your heart was fine.
Yes.
But you had a panic attack. Okay, which, by the way, they see all the time. All the time. So glad you had it checked out, and I'm glad your heart is
Me
fine.
too.
But let's figure out what we can do about this panic attack. Now, was that your first panic attack, or have you had others?
That was my first.
Okay, and have you had any panic attacks since that one?
I have not. The fear of having a panic attack has been the recent issue. So anytime I have kind of traveled since then, I kind of start to have thoughts.
Yeah.
And have I've seen a doctor and have started taking medication to avoid an actual panic attack.
Okay, all right. And panic attack is usually this discrete episode, and you describe sort of like the classic panic attack that happens. And you know, when you're in it, it's completely overwhelming. Even though it's 20 minutes, it's like the longest 20 minutes
Yes.
of your life. But panic attacks are really common. Sometimes they're caused, by life events, by losses, by accidents, by planes. Sometimes they come out of the blue.
Mm-hmm.
But panic attack becomes panic disorder when you have multiple attacks, or you have one attack and then you get really afraid of when the next one's going to happen. And in fact, you get so afraid of it that you start feeling anxious, and it's almost like pushing yourself towards the next panic attack because you're so afraid a panic attack is going to happen. You get kind of trapped in this cycle.
Yes.
So it sounds like if you're not there yet, you're sort of moving towards the panic disorder
Yes.
category, and you've decided at this point to use medications to prevent an attack from happening.
Yes.
So is this medication you take every day, or
No,
Okay.
just when I'm traveling.
Okay, so sounds like traveling would be a big trigger, and is it just airplanes, or is it driving and
Just airplanes.
Okay, so just airplanes, and you have a fear of a panic attack.
Yes.
So what medication do you take?
I have been taking Xanax.
You've been taking Xanax, and you take it before the flight.
Yes.
I guess shortly
Yes.
before the flight, and any other times when you take it?
No, I mean, if it's a longer flight, then I will take a second dose. But for the most part, it's just before boarding and before I have to sit on the plane for an extended amount of time with the door shut.
So this question will make more sense later, but do you carry Xanax around with you at all times?
Yes.
Okay. And we call that a safety behavior, and sometimes when people are so consumed with the idea that they might have one, they need that security of having a Xanax around. Mm-hmm. And while it helps in the short term, it actually undermines their ability to cope with anxiety on their own, because they can't attribute the absence of panic attacks to anything that they're doing. It's all because of the medication. So eventually where we want to go is to help you be able to fly without Xanax.
Yes.
When I say that, what's your reaction to that?
That I'd really like to. Okay. I'd like to enjoy flying again.
Yeah, okay. But I would guess it makes you a little anxious to think about that.
Yeah, because it's the lack of control then and being able to stop something before it starts, but it is also something I hope to achieve.
Clinically, a panic attack is defined as a sudden episode of intense fear that triggers severe physical reactions when there is no real danger or apparent cause. They may be cued. For Kathleen, it was getting on an airplane and thinking about a flight, or they may come uncued, completely out of the blue. Fortunately, they rarely last for more than 20 to 30 minutes. Now, often as an intake with a new patient, I'll ask them if they've had a panic attack. If someone says, well, maybe, or possibly, or I think I have, then I know they probably have not had a panic attack. By the very nature of panic, you remember it, and you remember the specifics of that panic attack very, very well. Panic disorder is what occurs when someone has had multiple attacks or has had one attack and now lives in terror of when the next attack might occur. A common fear that then develops in addition to panic disorder is agoraphobia, or fear of open spaces. People become afraid of leaving home because they may have another panic attack and other people may not help or rescue may not be able to find them. As with any patient in CBT, you'd first want to do a semi-structured diagnostic interview. We did this with Kathleen, then sent her home with a packet of questionnaires and some self-monitoring homework regarding anxiety and stress. So what are some good questionnaires that measure anxiety? There's the Beck Anxiety Inventory. That's a little bit hard to find online. There's the GAD-7, which is used in most primary care practices. It's available online and relatively easy to find in a number of different languages. There's the DASS-21, DASS, which stands for Depression, Anxiety, and Stress Scale. Not used as commonly, but a lot of folks like to use this because it includes both depression, anxiety, and also taps into measures of stress. As with nearly all treatments, CBT for panic disorder includes an early focus on patient education, including directly addressing any misinformation or misattributions the patient might have already made about the symptoms or the episode that they had experienced. We first want to name the disorder, a different version of name it to tame it, and then describe what's happening so that we can begin building an alternate explanatory model of what's going on. Patients often begin with an ambiguous, overly catastrophic model that blames themselves for their symptoms or may forecast a dire future, like they think that now their heart has been damaged and they're prone to heart attacks or perhaps having a stroke. By knowing their symptoms are a thing, a different sort of thing, a diagnosis, we can start nudging them in more helpful directions, including treatments. Let's tune back in to Kathleen as she learns about panic disorder and the panic cycle. So I think what we should do then is do a little bit of education on panic attacks and the panic cycle. From there, we'll talk about the different kinds of interventions and skills we want to teach you. We'll have you practice those skills outside of the session, just sort of out in the world in general. Okay. And I know your specific vulnerability is in flights, but we won't put you on a plane just yet.
Okay.
So eventually we'll want you to be able to use these skills on a plane, but we'll lower the stakes a little bit and you can practice just out in the world in general. So tell me what you know about, have you heard about the panic cycle, about what that is or how that works?
I have not. Okay.
So let's talk a little bit about that, and I want to show you a diagram of what a panic cycle looks like. So it often starts with a trigger, and the trigger is often a physical sensation. So you mentioned that your heart started beating really rapidly and you started hyperventilating a little bit. So you felt something in your body and it grabbed your attention. You were also in this context of this sort of stuffy, closed-in plane and were feeling kind of uncomfortable. So you're feeling vulnerable, you notice this physical sensation. You feel anxious about it. You note or you interpret the physical sensation as, uh-oh, what's going on, what's happening. It triggers a fight or flight response. And what happens when you have a fight or flight response? When you feel a rush of adrenaline, what does it do to your heart?
It just increases my heart rate even more.
Right, so it increases the heart rate even more. So you're having a fight or flight response. It probably raises your respiration rate, how quickly you're breathing, raises your heart rate, which then serves as proof, so to speak, that, oh my God, something is happening, something really serious or something catastrophic. So it's called a catastrophic misinterpretation of a benign physical sensation.
Heart attack.
Yeah, so you're thinking heart attack, which makes you even more anxious, which makes your heart rate go up even more, which makes you even more convinced that you're having a heart attack. So you suddenly start sort of spiraling upward as your heart rate's going up and up and up, your breathing rate's going up and up and up, and you become more and more convinced you're having a heart attack. Then you start to sweat, you probably develop a sort of tunnel vision, sort of all those symptoms come into play and don't go away until your body's kind of exhausted, usually after about 20 or 30 minutes or so. Does that sound like that fits what you experienced? So,
that's exactly what happened.
Yeah, so I'm seeing lots of nodding, and I think, first comes sort of the cognitive knowledge that, okay, this is a process and it seems to fit, it seems to work, but the way to actually break that cycle is to look at specific points where we can help you to reinterpret physical sensations as to what they really are, and it's, my heart rate's up. That's it. My breathing is faster now, and that's really it. We want to help you cope with anxiety better in general, so we'll teach you some relaxation. But we also want to help you be less afraid of those physical sensations. So we will do things that will create a higher heart rate, or that will cause you to breathe a little more rapidly, creating those sensations, giving you a chance to interpret them in a way that's non-catastrophic, and then seeing if we can't help you to control your anxiety that way. Although thought records can help, the most effective strategies are behavioral, with the most effective being exposures with response prevention. In terms of panic, it's called interoceptive exposures because you're being exposed to internal sensations. Let's take a quick step back, though, and elaborate on what I mean by exposure therapy. Now, exposure therapy was first developed in the 1950s and has become an essential component of cognitive behavioral therapy for anxiety. Exposure outperforms medications alone, but probably the best outcomes are often seen when you combine an SSRI with CBT with exposures. Success rates then tend to exceed 80%. Although exposure works well, it isn't always offered to people who need it. Part of the reason is that exposure work is really hard, and it really isn't all that appealing to anxious people. The trick, though, is getting over that initial hump and realizing that the short-term pain is worth the long-term gain. Let's return to Kathleen as she prepares for her first exposure experience. For her, it's the physical sensation of feeling lightheaded and having her heart pounding that triggers her anxiety. It's linked with the fear of flying, but it's more general than that. She avoids situations that might create those sensations and relies on Xanax to suppress those sensations. From an interoceptive exposure perspective, we want to do something that will cause her to feel lightheaded and raise her heart rate without Xanax on board. Let's play the next clip and see what happens. So Kathleen, you've made great progress with the relaxation exercises, both the meditation and also the breathing exercises. You've done a lot of good work on paper with challenging the catastrophic cognitions. So what I'd like us to do is to take it to the next level now, and instead of just doing those challenges on paper, to actually do them here live. And in order for those to be most effective, we need to raise our anxiety level. And I say our because I'm going to do it with you, right? And remember the trigger of that whole panic cycle was a physical sensation, and for you it was rapid heart rate and also an increase in your respiration rate. So what I'd like us to do is to purposefully, briefly hyperventilate together so that we can raise our heart rate and our respiration rate. What we hope that will do is it will increase anxiety and give you an opportunity to then challenge hot cognitions in your head. Now, what sorts of thoughts would you predict might pop up if you're feeling really anxious and your heart's racing?
That I'm having a heart attack.
Right, that you're having a heart attack, right. So we know that thought's probably going to pop in there, and we've written responses to that on paper. So I want you, in the moment, as that's happening, saying to yourself, this is a benign physical sensation. My heart rate should be going up because we're doing something to increase our heart rate. It's natural, it's normal, it's healthy. My heart's in good shape. I can manage this. So all those sort of reassuring cognitions to pull you back down and that pull you away from those catastrophic misinterpretations.
Okay.
Okay. So what we'll do, and I'll just tell you what we'll do so you know what to expect. We're going to rapidly breathe for about 30 seconds or so. It's not very long, but it will seem like it's a really long time. We'll do it together, and then at the end, I'm going to ask you some questions about how you're feeling. And I want you, if you're feeling anxious, you may not, if you're feeling anxious, to be working on those internal skills of fighting back against those cognitions.
Okay.
Okay? And when I say rapidly breathing, I mean rapidly breathing. So we will go like that for about 30 seconds, okay? And I will time it, and I'll just tell us when to stop.
Okay.
So you might want to just get comfortable. And 3, 2, 1, go. And stop. What's your anxiety like right now?
It's probably about a 7.
Okay, okay. Now use your skills, use your relaxation, use those cognitive challenges. What are the worries that came up?
That my heart rate was increasing because something was physically wrong instead of that we're doing it for a reason.
Okay, and how did you push back? What did you say? What did you think?
That my heart rate was up because we were doing an activity to increase it, and that something wasn't really wrong.
So it's a benign physical sensation?
Yes.
It's 100% explainable given the circumstances?
Yes.
It's not evidence that anything is wrong?
Yes.
Okay. And where's your heart rate now? Where's your anxiety now?
It's probably closer to a 5 or 4 now.
Okay, so it's decreasing.
Yes.
It's only been a few seconds.
Yes.
And fortunately, we have these fantastic cardiovascular systems that go up, they go down, they go up, they go down because they're responsive to our environments. And it doesn't mean that there's anything wrong. Right? Okay, so what we will do is we want to continue giving you the opportunity to experience mastery of your anxiety, even when triggered by a physical sensation like your heart rate. That means we need to think of different ways to get your heart rate up, different ways to get your anxiety up, so that you can then have the experience of grabbing that anxiety and pulling it down. And you did it here successfully in just a few seconds. So we want you to be able to do that over and over and over again. So we'll do it a couple more times together, but when you leave here, we're going to come up with a schedule, with a plan of where, when, and how you'll be able to do that between now and the next visit on your own. That usually makes people a little more anxious because you're not with your therapist, right? You're not in this nice controlled setting, you're sort of out in the world. But again, that's the whole point. We want it to be as real world as possible, so next time you take a plane and you're sitting on the plane, you start to feel anxious, you also have that memory of, I can handle this. I've done it. Been there, done it, got it. Okay? Right, so let's figure that out.
Okay.
Let's debrief what just happened. And let me start by saying that you shouldn't try this on your own. It's not particularly dangerous, but you wouldn't want to create a bad experience for yourself. Before this exposure exercise, she had learned about panic, learned some somatic quieting, and learned how to capture and challenge catastrophic cognitions. We had gone over what to expect, and she knew that I would be there helping her and doing the exposure with her. In a way, I was an initial safety behavior or safety clue, but remember that after we do this together, she'll have homework to go out and do it on her own. We want to keep upping the ante so that she can prove to herself definitively that she is the master of her anxiety, that those sensations are benign. Although this may seem risky or scary, I have never in over 20 years of doing this had a patient that was pushed into having an actual panic attack. It just doesn't happen. They absolutely get anxious and afraid of an attack, but that's what we want, so that they can beat that anxiety back down and master that anxiety. Let's recap the treatment for panic, and let me add that this treatment protocol is one of the shortest and most effective in our CBT playbook. The elements are education about the panic cycle, challenging catastrophic cognitions. We may or may not do somatic quieting. It's not always necessary. Those interoceptive in-session and homework exposures, and then, of course, being able to experience that high levels of anxiety and develop mastery. This is usually accomplished in a short 4 to 6 weekly sessions. But what about for everyday anxiety? Let's look at our toolbox to see what we might use. Feeling keyed up? Try somatic quieting. Feeling neurotic and ruminating a lot? Try a thought record or use some of our behavioral activation strategies for rumination. Overly fearful? Try exposures. Worrying? See Lecture 7. Now we can look at thoughts about the value of worry, different habits of mind, but we also want to use some of those behavioral activation strategies. What would you do for Amanda? For Miriam? For David? Take out your toolbox and think about what you might prescribe. But what if your loved one, a child or even a spouse, is anxious? What's the best way to be supportive? When is pushing him or her going to help because they have to face their fears? And when is it going to make the situation worse? Now, this is a tough one with no clear answer, but remember that all of us need to learn distress tolerance and tolerance for uncertainty. Think of these as developmental milestones or maybe skills of living. I've seen parents of kids with OCD who will check locks, sterilize the house, and avoid saying certain trigger words to help their child. I've seen siblings of people with social anxiety letting them sit in the car while they go inside to shop or make phone calls or to schedule their doctor's appointments for them. It's not on you to force exposure therapy. After all, you aren't their therapist. All emotional challenges, though, whether it's anxiety or depression, place stress on a relationship. So it's important to address and not just enable. At the same time, it's important to express love and non-judgment. You can still say no or disagree and still be supportive. You can also read about anxiety together. You can create a CBT toolbox together. You can even watch this course together. I'd say most of the emails I get are from family members worried about a spouse or a child. They're looking for a therapist. They're looking for resources because they want to help. Unfortunately, that old adage about leading a horse to water is true. You can open the door, you can offer to walk through the door with them, but you can't force someone to get help. If you're interested in learning more about how to help someone with anxiety, you might start with the website for the Anxiety Disorder Association of America at adaa.org. If you're interested in finding a CBT therapist, start with the online referral directory at abct.org, and you just click on the link that says Find a Therapist. And if you're interested in a more in-depth discussion of how to find help and evaluate the kind of help that you eventually come to, I encourage you to watch Lecture 24 of our last CBT course. Please join us for our next lecture when we turn to a common destructive behavior, chemical addictions, particularly opioids. Thank you.